This is Dr. Hessel dictating the podcast on basic cardiac anatomy, which was due on September 27th, 2016. Your reading assignments are in these three texts. I've also used some additional resources. This displays the anatomy that one would see when you open the mediastinum prior to cardiac surgery. However, normally you only see the center part. Note that in adults the thymus gland is mainly replaced with fat, and it overlies the innominate vein, which runs at the top of the incision across the upper mediastinum, and is at risk of getting damaged if the incision is extended too high. This shows after the pericardium is open. It also shows the underlying left innominate vein. Usually during a median sternotomy you really don't see the left anterior interventricular groove with the left anterior descending artery, nor the left ventricle, and often the pulmonary artery is not as obvious as it dives posteriorly to the right, to the left of the aorta. The main great structure that you see is the aorta coming out of the heart, and of course the left atrial right atrial appendage is usually visible. This is a view of the open right atrium. Notably is the crista terminalis, and remember that the AV node is just under the endocardium in the posterior wall of the atrium near the entrance of the superior vena cava. Also demonstrated are the fossa ovale, the eustachian valve, the Thebesian valve, and this notes where the AV node is located. There's a typographical error here. This should be the SA node, not the AV node. Note that the AV node sits anterior to the coronary sinus and just above the septal leaflet of the tricuspid valve. In the next couple of slides I will summarize the conduction system of the heart. It consists of these three main components. This diagram shows the components with the SA node at the junction of the superior vena cava and the right atrium, the AV node, the internodal conduction pathways, the AV bundle or bundle of His, and then the main branches going to the left and right ventricle. The SA node, as I mentioned, is near the posterior junction between the superior vena cava and the right atrium. It is a normal generator of a sinus rhythm, the primary cardiac pacemaker, and around 60% of the time its blood supply comes from the right coronary artery. There are thought to be special tracts that run from the SA node to the AV node, and in addition a tract that carries the impulse from the AV node into the left atrium. The electrical conduction through these internodal tracts is fairly rapid, requiring about 0.04 of a second. The AV node is located beneath the endocardium in the posterior wall of the right atrium, above the fibrous trigon, at the AV border, anterior to the ostium of the coronary sinus, and directly above the septal leaflet of the tricuspid valve. Its blood supply is predominantly from the right coronary artery in between 85 and 95% of patients, and in the circumflex from the balance. The conduction of electrical impulse is relatively slow through the proximal portion of the AV node and requires about 0.11 of a second, and this is responsible for most of the AV delay, the so-called PR interval. The myocardium of the atrium and the ventricles are electrically isolated from one another by the cartilages, or skeleton of the heart, and the only way for the conduction to pass is through special pathways. Normally, this is penetrated by the AV bundle of Hess, although in congenital abnormalities there are accessory pathways. The AV bundle is the distal portion of the AV node, and it pierces the fibrous skeleton into the membranous interventricular septum and passes onto the superior border of the muscular interventricular septum immediately below the membranous septum and beneath the junction between the right and non-coronary cusps of the aortic valve. The left bundle then fans out beneath the right coronary cusp. And this bundle passes the electrical impulse rapidly from the distal AV node to the ventricle. This diagram again shows the location of the SA node, the internodal tracts, the AV node, the bundle of Hess penetrating the fibrous skeleton and dividing into the left and right bundles. Notice the right bundle often sends a branch through the so-called moderator band to the lateral wall of the right ventricle. This shows the open left ventricle, showing the left bundle piercing beneath this junction between the right and non-coronary cusp, and then spreading out into the branches of the left bundle. This is also depicted on this diagram, showing the right coronary cusp and the non-coronary cusp. The AV bundle of Hess, after arriving in the top of the muscular septum, then divides into the right bundle and the left bundle, which then divides into the posterior and anterior bundle. They then end up, all of these bundles, in the Purkinje system, which is distributed throughout the myocardium of both ventricles. Conduction system through the AV bundle and the bundle branches, and the Purkinje network are very rapid. This is a final diagram showing the branches of the AV node, the Hess bundle, the left bundle, and the right bundle. On this slide, I have summarized some of the differences between the right and left ventricle in terms of shape, wall thickness, the nature of the atrioventricular valve, the trabeculation, the presence or absence of an infundibulum, and rather there is connection between the atrioventricular valve and the ventricular atrial valve, the compliance and the type of pump. This open view of the right ventricle showing the tricuspid valve, the moderator band, but most importantly the infundibulum or the conus of the right ventricle. This is unique to the right ventricle, and as you can see is a tube that joins the body of the ventricle to the pulmonary artery, and thus the pulmonary valve and the tricuspid valve are separated from one another in distinction to the left ventricle. This is an open view of the left ventricle, first showing the mitral valve with the anterolateral and posterior medial papillary muscles. This is the posterior leaflet and the anterior leaflet. The mitral valve has been cut off at this point, but you see it's directly adjacent to the underlying aortic valve. I've already shown this picture of the conduction system coming out onto the subendocardium of the left ventricle. Importantly, when surgeons are operating near the aortic valve, you can see how the conduction system could be at risk. This is a view from the top showing the valves of the heart. The front is here and the back is here. A tricuspid valve with the anterior, posterior, and septal branches, leaflets, and the mitral valve with the anterior leaflet and the posterior leaflet. Here are the two pulmonary and aortic valves. Remember, the non-coronary cusp, the right coronary cusp is directly anterior. The left is left posterior lateral, and the non-coronary is right posterior lateral. This shows these same valves during ventricular systole. So the AV valves are closed and the VA valves are open. This is a more detailed view of the RV outflow tract, showing the anterior leaflet of the mitral valve in juxtaposition with the aortic valve. This is the left coronary ostia and the right coronary ostia, and this is the non-coronary cusp. This shows the tricuspid valve open. Here is the coronary sinus, the location of the AV valve, AV node, and the leaflets. Note the septal leaflet just underneath the AV node, and the anterior leaflet and the posterior leaflet. Notice that there are multiple papillary muscles on the right ventricle. On the other hand, this shows the mitral valve with only two leaflets and two main papillary muscles. Next, I would like to talk about the coronary arteries. We speak of three coronary arteries. As you know, there are actually only two main, the right main and the left main, but we refer to the two main branches of the left main, the LAD and the circumflex, as the other three. So the three vessels are the right main, the LAD, and the circumflex. The right main coronary artery comes off the front of the aorta from the right coronary sinus. It then passes in the right AV groove posterior to the crux of the heart, the junction of the AV and interventricular septal planes. The branches of the right are the conus branches to the infundibulum, the artery to the SA node, the artery to the right ventricle, the arteries to the right ventricle, which are called the right ventricular marginals or the acute marginals, the posterior descending coronary artery, the artery to the AV node, and the posterior lateral branches to the left ventricle. The term dominance refers to which vessel, the circumflex or the right, supplies the posterior descending, the AV node, and the posterior lateral branch. In about 80% of the time, these three branches are supplied by the right, and in about 10% from the circumflex, and in about 5% equally from both. The left main comes off of the left posterior lateral part of the aortic root. It runs behind the pulmonary artery to the front of the heart, where it divides into the left anterior descending and the circumflex. Sometimes there's a third branch, the so-called ramus intermedius, which comes off the crotch between the LAD and the circumflex and runs down the anterior lateral wall of the left ventricle, taking the place of the first diagonal and the first obtuse marginal. The LAD gives off the septals and the diagonals, while the circumflex gives off the left ventricular marginals called the obtuse marginals. And as we said before, in a 10 to 15% of cases, the artery to the AV node and the posterior descending artery. I've already mentioned this third vessel, the ramus intermedius, which occurs in perhaps about 10 to 15% of patients. On the next few slides, I've shown the epicardial vessels which we have just described. This shows the left main coming off of the aorta, running behind the pulmonary artery to the front, where it divides into the LAD and the diagonal and the circumflex. Over here you see the LAD, the circumflex, I'm sorry, the right coronary artery coming off of the front of the aorta and running in the left, the right AV groove between the atrium and the ventricle. The circumflex runs in the left AV groove between the atrium and the ventricle. Here you see the back of the heart. This is the inner ventricular septum. This is the left ventricle and the right ventricle. Here is the right coronary artery running in the right AV groove and continuing to supply the posterior descending coronary artery and these posterior lateral branches of the left ventricle. Over here we see the terminus of the circumflex giving off these obtuse marginals. This is the back of the heart when you have a left dominance, so you see the circumflex running in the left AV groove and supplying the posterior descending coronary artery and also the posterior lateral branches. And this is an example of the balanced circulation, where you have two posterior descending coronary arteries, one from the right coronary artery and the other from the left circumflex. On the next few slides, I'm going to show coronary angiography, which I think is helpful for you to normalize. I like to think of this anatomy according to the planes of the heart. This shows the AV plane, which divides the atria from the ventricle, and this is the interventricular plane, which divides the right side from the left side. The LAD runs in the anterior interventricular plane, while the circumflex runs in the left AV plane, and the right coronary artery runs in the right AV plane, and finally the posterior descending runs in the posterior interventricular plane. There are two main views that are used to depict coronary angiograms. One is the right anterior oblique view, which comes in this direction and is also illustrated on this view of the surface of the heart. The other view is the left anterior oblique view, which comes in from the left anterior oblique region, and this shows the epicardial anatomy of the heart as viewed from the LAO plane. So now this is a picture of a right coronary angiogram from the RAO view, and you see the right coronary artery coming down vertically in the AV groove, and then the PDA running down here. this is better displayed in this picture here. So again, in this RAO, this is an LAO view looking from the other direction, and we now see the circumflex running in the AV groove and the all along here, and the posterior descending is coming out towards us. Let me go back to this right RAO view of the right coronary. Although not depicted on this slide, you would see the vertical running circumflex and then a horizontally running PDA running along in this direction. So this is another depiction of the right coronary angiogram in the LAO view. And so again, we see the circumflex running in the AV groove on the right side, and then we see the posterior descending coming out towards us. You can nicely see the artery to the AV node and the posterior lateral branch going to the left ventricle from the right coronary. Now we'll show left coronary angiogram, and this is a LAO view. This shows the epicardial picture, and this shows the angiogram. So you see the circumflex running vertically in the AV groove, and the left anterior descending running on the anterior surface of the heart. And then you see these obtuse marginal branches from the circumflex going on to the wall of the left ventricle. This is another left coronary angio in the LAO view, showing the left main, the origin of the left circumflex running in the AV groove. And in this case, this is left dominance, and so the circumflex is supplying the PDA running in the posterior interventricular groove. The LAD you see coming off and going in the anterior interventricular groove. You also see some septal branches coming off of the LAD and some diagonal branches. This is a left coronary angio in the RA view, and now you see the circumflex running vertically in the AV groove, and you see the LAD running on the anterior surface of the interventricular groove with diagonal branches, and then this is obtuse marginal branches. This is another RAO view of a left coronary angiogram, showing again the vertically running circumflex with the obtuse marginal branches and the longitudinally running anterior descending coronary artery. On this slide, I have depicted the autonomic innervation of the heart coming from the vagus system, the parasympathetic system in the vagal nerve, and the sympathetic surface system off of the spinal nerves. And this is a diagram showing the various autonomic nerves coming into the heart, which is richly supplied by the autonomic nervous system. Here would be the parasympathetic vagal system, and you see the sympathetics coming off of the ganglia of the cervical spine, the thoracic spine. It is interesting that the muscles of the heart are arranged in a spiral fashion, and they interconnect both the right and the left ventricle. And this shows the pattern of the spiral flow of the myocardium between the left ventricle and the right ventricle. It's also helpful for you to understand the microanatomy of the heart, and I recommend that you study this in the textbooks. The heart, the myocardium is a syncytium of myocardial cells joined at the so-called intercalcated discs. This shows the ultrastructure with the thick filaments, the so-called myosin filaments, and the thin filaments, the so-called actin filaments. And as you recall, and we'll discuss under physiology, the interaction between these two filaments is what causes contraction. This is in diastole, and this is in systole. Next, I would like to just briefly show the gross anatomy of the basic TEE views. This is the anatomy that you see in the four-chamber view as illustrated over here. And so we see the left atrium, right ventricle, left ventricle, the tricuspid valve, and the mitral valve. And here's a display of the diagram. The five-chamber view is shows not only the two atria and the two ventricles, but also the outflow tract of the left ventricle, and that is illustrated in this diagram. Finally, the long axis view shows the left ventricle and a little bit of the right ventricle, the interventricular septum, but most importantly, the outflow tract of the left ventricle and the aortic valve. So we see the left atrium, the mitral valve, the left ventricle, the outflow tract of the left ventricle, the aortic valve, and a little bit of the right ventricle, with the anterior interventricular septum here. And finally, this is the short axis mid-papillary transesophageal view of the two ventricles. This shows the view that we typically see of the aortic valve in the short axis. We don't normally see the mitral or tricuspid valve, since they are located at a different level than the aortic valve. What we do see is the left atrium behind the right atrium over to the right, and the right ventricular outflow tract in the front. Notably, though, we see clearly the three leaflets of the aortic valve. The one in the front is the right coronary cusp, the one left posterior is the left coronary cusp, and the right posterior is the non-coronary cusp. And finally, this shows the long axis view of the aortic valve. The valve in the front is always the right coronary cusp. The valve in the back is usually the non-coronary, but it could be the left coronary cusp. In closing, you should remember the idiosyncrasies of the fetal circulation. Remember that the umbilical vein from the fetus comes in to the ductus venosus, which largely empties into the inferior vena cava. The blood then comes up and goes across the interatrial septum into the left atrium, and then into the left ventricle. It pumps out of the left ventricle, but predominantly then goes to the descending aorta. Note that the blood coming from the superior vena cava, which is largely desaturated, comes through the atrium and tricuspid valve out the pulmonary artery, but because of the high resistance, this blood is then shunted into the descending aorta. So the descending aorta gets relatively desaturated blood, which then comes out through the umbilical arteries to the placenta to get oxygenated. The oxygenated blood from the placenta then comes back from the from the umbilical vein to the inferior vena cava, where it is diverted into the left heart and into the ascending aorta. So the heart, the brain, gets the most oxygenated blood in the fetus. On the following slides, I have given your study questions, which have also been delivered to you on Wiki. And that completes this podcast.